Now I would like to request our speaker, first speaker, Dr. Shivakumar F. Kumbar, to come on the dais. He'll be delivering a talk on death on table, what to do next. I would like to request our chairperson to kindly introduce our speaker.
Dr. Professor Shivakumar F. Kumbar. He did his MBBS from MR Medical College, Kumbar in 1982 to 1987. DA, Karnataka Institute of Medical Sciences, Hubli. LLB, Karnataka University, Dharwad. LLM, Kumbar University, Shivakumar. MBA, Hospital Administration in 2015 and 16. MA in Journalism, Mysore University, Karnataka, 2022. PGD MLS, Postgraduate Medico-Legal Systems, Symbiosis, Pure. PGD MLE, Postgraduate Medical Law and Ethics, NLSIU, Bangalore. CCEPC, IAPC, Pain and Palliative Care, Kidwa Institute, Bangalore. CDM Certificate in Dispute Management, IIAM, Cochin. FIA MS Fellowship, Fellow of Indian Academy of Medical Specialties, 2008. Bioethics International Chair, UNESCO Bioethics and Human Rights. Vice President IMA Karnataka State, 2016 and 17. Chairman IMA AMS Karnataka State, 2020 and 22. President ISA Karnataka, 2023 and 24. Honorable Professor, IMA National Academy of Medical Specialties, 2022. IMA Headquarter Member Standing Committee of Legal Cell, 2020 and 22. IMA Headquarter Member Standing Committee of Rural Health, 2021. IMA HQ Member Standing Committee of Ethics, 2024. Profession Consultant Anesthesiologist and Medico-Legal Advisor and Pain Palliative Care Therapist, Accredited Mediator from IIAM Institute. Over to you.
Thank you very much for brief introductions. Good morning to everyone. I vote to the organizers of this esteemed conference to be the part of this conference for me. And I'm going for the last 4 or 5 days. You have been with the only academics. Today, I would like to take you beyond your academics. So, how many of you have come across institutions of private practice, death on the table and Bishop on the table? Can you raise? Yes. Very honestly, people raise. Most of the people, they do not raise their hands. I presume still it's a social stigma, or else they have not handled enough cases, or else judicially they are telling lie, or else they are beginners, they are ready to start a practice. Okay. So the important topic what is given to me within a given time, I will try to finish it off. Death on the table, what to do next. Friends, we got into this medicine more so unsure profession because we value the life and want to save the people. What do you do when you can't save that life which is beyond your capacity? So that is the topic which I am going to deal with right now. So there are many misnomers for the death on the table. So death occurring on any table where patient is going any procedure, maybe a medical or surgical, under the care of anesthesiologist, or patient dies before the surgery could be completed, or at the end of a just and otherwise technically perfect and surgical operation. Many times even the surgeons would not have draped the patient, but you have a cardiac arrest. The onus falls on you, not for the surgeons. So what exactly is anesthetic death? Death occurring within 24 hours of the administration of the anesthesia due to causes related to the anesthesia where you do not know the underlying cause. But you know the cause could be because of anesthesia, but you are not sure of it. It's called as anesthetic death. So what are the places where you can encounter death on the table? Death does not mean that only operating table, but it can be a labor table or maternity or medical procedures where you are going to do lumbar puncture, epidural, central line, or chest drainage procedures, many of the radiological procedures and procedures done under local anesthesia, or else even it comes when you are giving the ECT procedures also, we consider it as a legally is a table only. So many times you have been called as a standby anesthesiologist, especially for the ophthalmic cases, where you will be called as a standby anesthesiologist. Whenever there is a mishap on the table, you will be rushed over there. So you please do not accept as a standby anesthesiologist unless you have seen the patient pre-operatively, or else you have seen the setups in the operative procedures. So if you do not have anything over there and you are called over there, you have an agreement with the surgeons that you will be the standby anesthesiologist and you will be getting the remunerations. If something goes wrong, you will be held responsible, sir. Please make it a point to accept the post of standby or a local anesthesiologist. All your procedures as per the standards of the ISA are there, then only accept it. Otherwise, please do not accept it. I have come across lot many cases for the last 10 years where the anesthetist has been called as the locum anesthetist or standby and they landed up in a problem. Next. The literature says the first case of a death related to anesthesia happened on-the-table death happened in 1947 due to pulmonary disease, where the brandy was administered to counter the effect of the chloroform. This was the first documented case of the on-table death, or I would say Mysore. The incidence of this on-table death is 0.5 to 0.8 per lakh anesthetics. Intraoperative death of anesthetized patient is 1 in 30 per 1 lakh, of which 80% deaths are occurring in emergency. This is mercifully very drastic reductions in the incidence of on-table death because of the newer modalities of monitoring systems and vigilance of anesthesia, and also because of the medico-legal hurdles. So what are the causes which you come across? The human error is the factor in anesthesia practice, and the circumstances tend to be immediate, adverse and conspicuous. The extremes of these are very vulnerable for the on-table death and associated comorbid conditions, ESC grade 3 and grade 4, but if at all it occurs in grade 1 and grade 2, it is a disastrous. Surgical factors I don't want to deal. Unnecessary factors are many times is the overdose, wrongful leveling of the drugs, wrong routes, accidents and intubation, anaphylaxis, inadvertent hyperactive nature and malfunctioning of the machines. So what is the immediate reaction of anesthesiologist? Cardiac arrest, yes, 90% of the cardiac arrests are reversible on the table, provided you are very vigilant and the systems are available to help you. Check the equipment, drugs, debriefing the OT team, accurate records, dealing with anesthesiologist wherein you have to call a senior anesthesiologist to help him, and do not run away from this scene. Never do it. Immediate cover up and unnecessary expenses not warranted nowadays. Settle a matter as early as possible by political financial means. Never do it, and you should not be too confident to deal with such things. So what are the delayed actions? The first thing is you must inform the insurance company where you have indemnified it. And I'm going to take another 1 or 2 slides, your liabilities also. Is it necessary to inform the police whenever death occurs in the operating table? So if you go for the forensic experts version, yes, they say that yes, every death on the table should be informed to the police. It should be made as a MLC. Friends, it is a misnomer. Never do it. Law does not want it. There is no law or judicial principle or pronouncement in support of the belief held by the many doctors that every death on the table should be informed to the police. The basic principle is that doctors should inform the police as soon as the suspects are foul play. If it is unnatural death. Death on the table is not at all unnatural death. It is a natural death, or you can call it as unexpected death. So there is no reason for the doctors to inform the police unless the foul play is suspected or where the cause of death is not assessed by you. You know the cause of death. If the relative is not accepting it, then you inform the police. Otherwise, there is no reason for you to inform the police if there is a death on the table. It goes without saying that every unnatural death should not be labeled as a MLC. So what exactly is unnatural death then? A death caused by external causes, maybe like a homicide, suicide, okay, and road traffic accidents. You can be taken as unnatural death, but not death on the table. In Haryana Medical Legal Manual 2012, also it defines that medical legal cases or death on table need not be informed to the police. Rather than inform the police about the death on table, what is needed is documentation is very, very important, complete and well preserved, so that they can be produced if the law enforcing authorities will ask you in due course of time, provided the relatives or attendants inform the police and make it a MLC. So as per the CRPC, Criminal Procedure Code 40 talks about the unnatural death. And CRPC 174 and 304B also deals with the unnatural death, but it never talks about the on-table death. So none of these sections and the case laws related to the same suggest that death on the table is unnatural death. So relatives denying the post-mortem, what must you do? In this very important case, Sir Ajay Chakravarti versus Srimati Babu Balendra in West Bengal, the relatives declined for the post-mortem and body was sent into it. The relatives filed a case in the court stating that the doctors prescribed us not to inform the police, so who took away the body for our funeral. Ultimately, it came to know that they had given an undertaking to the police. Our rituals will not permit us to go for the post-mortem. We want our own will and accord to take the body for the funeral. They have given it in the writing so that doctor could be saved here. So law is not what the lawyer or the law graduate or any specialist or intelligence claimant thinks. Law is written in a statute or the judgment of the High Court or the Supreme Court. So by routinely inform the police about the death on table, what may result? Unnecessarily delay in the OT work, unnecessary workload on the hospital administration, unnecessary workload on the police, unnecessary likely harassment of relatives by the police. So when PM or autopsy is needed, I said PM is being requested by the investigating officers. Please, I am going to repeat it. It is requested by the investigating officers, that is none other than the police or the magistrate. So police under section 174 CRPC and the magistrate under 176 CRPC with the following objectives, they inform the police to do the post-mortem, otherwise they do not. They can waive off the post-mortem, but the doctors cannot waive off the post-mortem, but his duty is only to inform the police. So to find out the cause of death, because where you do not know the cause of death, it is anticipated, or if you know the cause of death, the relatives are not agreeing for that. So that time you have to ask the police people. So waiving of the post-mortem, medical legal PM is done on request of the police, magistrate or a court. Medical officer who has no power to waive the post-mortem. So again I am going to stress you, a death or a natural death, it is the property of the relatives, unnatural death is the property of the state. Okay, when you call it the state, automatically it comes to the district administration like a police. Medical officer has no power to waive off the PM. He can play a role of advisor in such cases, but final decision lies with the investigating officer, that is none other than the police people. The police only being a principal investigating agency and the rightful custodian of the body and the authority to waive off the PM. This is also very, very important. So, the consent or permission of the relative is not required for the conducting medical legal PM. So, police cannot say that relatives have not given the consent, we want to waive off the waive off. First, he does the Panchanama. He looks into the documentation and he takes the written and the oral version of the doctor as well as the opposite party, then he decides. So taking away the patient or the body of the medical legal cases forcibly by the attendant. Many times you do come across. So if you have labeled it as a MLC, never ever do to release the body unless you inform the police. So what if a FIR is registered? It's also very, very important. If the FIR registered in spite of all this being done by the police officers, because most of the police officers do not know about this. So we have certain sealing mechanism, what we call the judiciary debt. Yes, do not get panic. Involve the IMA or the ISC or a senior anesthesiologist. Involve medical legal experts or the lawyers who deal with such kind of a. There is no point in informing the civil advocate. He will make a mess out of it. Prepare the list of things handed over and get them and countersigned. Medical expert opinion is a must before the FIR is registered. I have won about 6 to 9 cases wherein a doctor was booked under 304A without the expert opinion. When we got it squashed in the High Court many times. Okay, filing of application before session judge of the High Court for the anticipatory bail under section 438, if at all it is falsifically, vexatiously FIR registered. And filing a writ petition under 226 of the Constitution before High Court to squash the FIR, which I have already told. So with all this, what are the defences available? Yes, we have plenty of defences available, which you do not make use of them just because we become very panicked. So these are the many of the defense available for us, including the Supreme Court judgments. It categorically says that every death on the table cannot be taken as the criminal negligence. We have to go into the details of it unless the law warrants you. So it's very important. I'll take another 30 seconds, sir. Difference between 304 and 304A. Most of the police people, when the FIR registered or when the case is filed, they book you under only 304A. Friends, most of the police authorities do not know about this. This is a non-bailable 304 and they are not supposed to book under you. Totally wrong. In this section, there is an intentional act of negligence. There cannot be intentional act of negligence on the operating table. Okay? Under 304A, the act is never done with the intention of to cause death and this is a bailable. Breaking the bad news against a big topic. Legal access, yeah, they can go to the consumer laws, criminal cases, complain to the administrative authorities like the local, as the DC or the DHO, complain to respect to state medical council to erase our name or to take a disciplinary action, or they can invite the media and demand for many or violence against doctors. Very, very common, especially with the death on the table. These are a few of the case laws where you have come across where the anesthesia was called for the radiological procedures. They have given a propofol, the baby died. They have given a propofol for the CT MRI, where there is second digit of weight because of the CA breast. Again, the patient died. So such of the cases which cannot be taken easily unless there is a minimum research equipment, you cannot take the case even for the IV solutions. With this, I think, sorry if I exceeded for 1 minute. Thank you.